pediatric musculoskeletal disorders. Common pediatric orthopedic injuries are outlined in this table on the next page. We'll look at that. But the first topic that I want to actually jump into is Duchenne muscular dystrophy. We'll look at these pediatric things, these right here, all of these at a separate time. First, I want to look at these musculoskeletal ones, the muscular dystrophies. These tend to, of course, when you get a question on any one of these, all of them are answer choices, so you got to be careful with that. An X-linked recessive disorder resulting from a deficiency of dystrophin, a cytoskeletal protein. So oftentimes you get the answer choice saying deficiency of some cytoskeletal protein. Onset is usually at 3 to 5 years of age. Female carriers can be symptomatic depending on severity of disease. Affects the axial and proximal muscles more than the distal muscles. May present with progressive clumsiness, fatigability, difficulty standing or walking, difficulty walking on toes because the gastrocnemius is not being as long as it's supposed to, and something called the Gower's maneuver, where you have to use both hands to actually help yourself stand up. And they of course have a waddling gait because all their muscles are not that good. Right, dystrophin is actually the largest protein that humans make, like the largest gene to make a protein as well. So that gene, obviously being as huge as it is, has a lot more opportunities to get mutations. And right here, the age thing, age is going to be a huge factor in figuring out what the answer is, as you can see from the table as well. We'll come back to the table when we look at all the muscular dystrophies. Pseudohypertrophy of the gastrocnemius muscle, and intellectual disability. Intellectual disability is actually not seen in all three either. So it is seen here in Duchenne, and then we're going to see it in the CTG repeat as well. So there's a table they have again for the differential diagnosis of DMD and Becker, and we're going to look at that. Main thing for diagnosis, of course, you're going to look for elevated CK levels. Elevated CK is a huge fact pointing at DMD, Duchenne muscular dystrophy. Confirmation is made with genetic testing, where you're going to see that the dystrophin gene is mutated. Optional muscle biopsy shows necrotic muscle fibers with absence of dystrophin protein, so the anchor won't be there, cytoskeletal protein. Negative dystrophin immunostain and high CK is generally all you really need. Electromyography shows polyphasic potentials and high recruitment. This they can actually tell you in a question, and this is actually very specific to Duchenne. Like, they don't need to tell you anything else. If they tell you they did an electromyography and there was polyphasic potentials, that's DMD. Right? So then they will just not tell you anything else in that table, in that question, and you'll be done. So for treatment of DMD, really you can't do much. There's nothing that can be done. Physical therapy is necessary to maintain ambulation and to prevent contractures. Liberal use of tendon release surgery may prolong ambulation, but that's about it. Mortality is caused by high output cardiac failure, which is going to be the cause of death that you have to pick as an answer choice, right? High output cardiac failure. So that's your DMD, Duchenne muscular dystrophy, the first thing, right? X-linked recessive, so it can occur, well, it'll mainly occur in men because men only have one X chromosome, but it can have symptoms in women, right? Now, if you get a question about a female patient presenting with weird symptoms, because of course you can have a female carrier, right? But the female carrier is not going to have this level of severity in the disease at this age, right? So then a female carrier of Duchenne muscular dystrophy often looks a lot like someone who has Becker. And that is actually probably the hardest type of question you can get on this. Right? So you have to be very careful in figuring out, is it Duchenne or is it Becker? And now we're going to look at Becker to see what the difference is. Or we're not going to look at Becker. They don't talk about Becker? They do not talk about Becker. So we'll go back to the step 1 book to look at it. They have a table here though, the same as the URL table. One of the main things that I usually look for to figure out it is Duchenne is the intellectual disability, right? So again, you could have a female that is a carrier of Duchenne, right? So since she has a good X chromosome and a bad X chromosome, she'll have some symptoms of Duchenne, but she is still capable of making some good dystrophin protein. So then her symptoms are not that bad. She may have had Gower's, when she was little, she needed to use her hands to stand up or something. That may have occurred when she was little. This is supposed to be maximally symptomatic by age 5, where all the muscles are not strong or long enough to actually function. But the girl that has Duchenne is going to make it further to like age 10, where she may have now started facing a little more difficulty. And of course, if the patient is age 10 female, you will really not think of Duchenne, right? Because Duchenne, we think of a male patient, we think of a younger patient up to age 5. So this is why that's the hardest question. You get a question about let's say you get a question about a 9-year-old female with muscular problems, and they describe a bunch of dystrophy stuff. But then at some point in the question, they might tell you that she's doing great educationally. The school has been perfectly fine. No intellectual disabilities. She has friends and stuff like that. Then, all of those things together fit perfectly into Becker because no intellectual disability. Similarly, though, they could have the same question again. 9-year-old girl had some muscular dystrophy issues when she was young, but she's doing okay right now. A little bit of muscular problems, but nothing so crazy. However, then they describe to you intellectual disability. Now you're not thinking Becker, right? So intellectual disability is the main thing that I like to associate to PIG DMD. It really helps because it's not a really prominent thing in Becker. And when we get to MTG, we're going to see more of that. So now, as you can see, they don't really talk about it too much here, right? They for MTG, myotonic muscular dystrophy, I just call it MTG because it's the CTG repeat. Autosomal dominant disorder causing impaired muscle relaxation. Look for an abnormally long handshake on USMLE, which actually is the thing in most questions. I think it might be in this question too. Other symptoms include dysphagia, balding, testicular atrophy, and cardiac conduction abnormalities. They don't talk about it too much here. So now we can just jump over to the step 1 book to look at the actual breakdown of what you're supposed to know about these. So in step 1, when we were talking about this, I broke it up in terms of age. That was, of course, the primary thing, right? So age of onset, Duchenne before 5 years, Becker 5 to 15, myotonic 20 to 30. Myotonic takes the longest to actually have crazy symptoms. This image here is showing you what the Gowers thing looks like. As you can see, the child is using the hands to get themselves to stand up, and they have this lordosis, which again is a result of scoliosis as well. So you see both things together. Right, so Duchenne, they tell you the same things, but there's a little more information here now, which for completeness purposes is actually necessary. So X-linked disorder, typically due to a frame shift deletion or nonsense mutation. So remember what these meant. A frame shift mutation meant that there was a deletion of some number of trinucleotides that is not a number divisible by 3. So if you delete just 2, the entire frame shifts down. Now you're going to be reading the wrong pairs of 3's, right? That was a frame shift mutation. And then nonsense, there was a mnemonic stop to nonsense, because nonsense mutations was the insertion of a stop codon somewhere. So now you have this super long gene that all of a sudden isn't so long anymore. So you're not going to make the full dystrophin protein. You get a truncated or absent dystrophin protein, leading to progressive myofiber damage. Weakness begins in pelvic girdle muscles and progresses superiorly. And you get some pseudo hypertrophy of calf muscles due to fiber fatty replacement. So it's called pseudo hypertrophy because it looks like the muscle is getting bigger, but it's not. It's not hypertrophy. It just looks like it's getting bigger, but it's really just fatty infiltration, which they didn't mention at all in the CK book, right? So fatty infiltration of muscle fibers is a key finding for you to also think of dystrophin and Duchenne. So they tell you dystrophin gene is the largest protein coding human gene, and of course because of that it has a high chance of spontaneous mutation. Dystrophin helps anchor muscle fibers, primarily in skeletal and cardiac muscle. It connects the intracellular cytoskeleton to the transmembrane proteins alpha and beta dystroglycan, which are connected to the extracellular matrix. Loss of dystrophin leads to myonecrosis, right? So again, you can't have necrosis and actual hypertrophy at the same time. So it is really myonecrosis with pseudohypertrophy of fibrofatty replacement. These are some terms that of course can be answer choices telling you, Duchenne is the answer. So gotta watch out for that. This was a really interesting question. The clinical progression of Becker muscular dystrophy is typically much slower than that of Duchenne muscular dystrophy. Which of the following mechanisms best accounts for the different clinical scenarios? So where was that? Oh yeah. All right. So Becker muscular dystrophy is typically much slower than that of Duchenne muscular dystrophy, which is true. This is why the Becker patient is going to be the older patient, because it takes longer for the symptoms to kick in, whereas Duchenne starts kicking in as soon as the child turns 2. So now they ask you which of the following mechanism best accounts for the different clinical scenarios. Why are they so different from each other? Well, Becker's is also X-linked, as you can see. Right, so they're both X-linked, which in that aspect, you usually for both of them, you usually think it's going to be a male patient. X-linked disorder typically due to a non-frame shift mutation, which means that it could be any mutation that is not causing a frame shift. So if you're going to delete something, you'll be deleting a multiple of 3 or adding a multiple of 3. Less severe than Duchenne, onset in adolescence. So because this deletion is not going to ruin the entire protein, it works out a little better. So if you think about how frame shift really works, you can imagine 1, 2, 3, 4, 5, 6, and 7, 8, 9. Right now, if there was a mutation that deleted the 6, then everything would move down, and your new pair would be 1, 2, 3, 4, 5, 7, and then 8, 9. So of course this is going to be the wrong protein, and this won't even give you a protein. So now you're going to make something really dysfunctional. That's what happens in Duchenne. The whole thing gets messed up at such an early age that you get really severe symptoms, right? So here for this, the answer is A, an in-frame deletion or insertion in the Becker form. In-frame means that you deleted a multiple of 3, and a frame shift deletion or insertion in the Duchenne form, right? If you add or delete a multiple of 3 in the same example I put here, then at least everything is still going to function. For example, if in between here I was to insert a multiple of 3, like let's just say like 333, right? Just a 333 in between here, then at least I'll still make this amino acid, I'll still make this amino acid, and in between I'll have another one stuck in there. But theoretically speaking, most of the protein should still be pretty good, and it should still fold the way it's supposed to in the quaternary distribution and have the correct quaternary structure. So it'll still work, just not as optimally as it's supposed to work, right? So that's something technical you can get as a question, more plausible of a question in step 1. But as you can see, both of these are X-linked, right? Both of these are X-linked disorders. Both of these can have symptoms in the girl as well. They could also tell you a question about a patient who has a sister who has similar symptoms, but she's actually okay. Key thing here is that Becker does not have any, and they don't really even talk about it here, actually. It's pretty strange. But Becker doesn't really have any what do you call it, intellectual disability. None of that, right? You're going to have intellectual disability in Duchenne, not so much in Becker. And then the last one, the myotonic type 1, this is a trinucleotide repeat, autosomal dominant. This is usually going to be a female patient in your question, but even here they avoid using female patients in general. For all the musculoskeletal dystrophies, if they're really feeling like an asshole, they'll use a female patient, but it's usually going to be a male patient. And the reason for that is that this CTG is supposed to remind you of cataracts, 2P, and gonadal atrophy, because these are going to be men who grow to like age 20, 24, start having some weird muscular problems, and have cataracts, and have frontal balding, and have gonadal atrophy. In fact, this question can even start off with a patient coming in because they're having infertility problems, right? That might be the actual basis of the first sentence in the question. Infertility problems, and then upon physical exam you notice that they're having some weird muscle wasting, right? That's not normal for any human to have muscle wasting, and they can die because of heart block. So that's the other thing. All 3 case scenarios here, the patient dies because of some kind of cardiac manifestation. But myotonic dystrophy, this one, there you can die because of heart block, whereas the other ones, it's heart failure, right? And they tell you here, right? So this URL table is probably the most complete version of all 3 topics. Both Duchenne, Becker, X-linked. Duchenne is younger, Becker is older, right? They both have muscle weakness. They both cause the patient to die because of cardiomyopathy, and they both eventually become really problematic where the patient just has an early death, right? So there's no cure. The prognosis for Duchenne is not so good. The prognosis for Becker is a little better. At least the patient may make it to age 40, but Duchenne patients do actually typically die by age 20. The high output cardiac failure is just too much to manage. There's no medications that can help them that much either. Symptomatic treatment is very useless at that point because they don't actually have the muscles. It's not that they're having heart problems because of cholesterol or hypertension or anything like that. Coworker, let's see. Um, And then the classic myotonic dystrophy, that one is probably the best version of these to have, but it still ends up being a whole different problem. Like, no one of these three is actually anything anyone would prefer. If you had to pick between one of these three, you would probably want to pick Becker because, and again, no one wants Duchenne, that's for sure. But between Becker and myotonic dystrophy, the myotonic one, the biggest problem in myotonic is that you can't even really have kids because of testicular atrophy, right? So that's like really bad. And then the aesthetic aspect of the weird frontal balding they start having at a very young age is also really problematic. And look at the reason of death, right? Death from respiratory or heart failure, depending on age of onset. Right, now, of course, in your question, the patient is usually alive, and we can look at some questions right now too. So here we have a question on MTG. 15-year-old previously healthy boy brought to the office due to progressive muscle weakness. Over the past 2 months, he's had increasing difficulty making facial expressions, including smiling and frowning. He has also had difficulty swallowing, but no pain. So that right there is the dysphagia, which is one of the things in CTG. He takes no meds. Vaccinations are up to date. He was adopted as an infant, and his biological family history is unknown. Physical exam shows ptosis, temporal wasting, thin cheeks, and emaciated extremities. Delayed relaxation is noted on contraction of the thenar and hypothenar muscles, which also appear atrophied. Deep tendon reflexes are normal, and Babinski sign is absent, so neurologically everything's fine. Then they give away the actual diagnosis by telling you that testicular volume is actually small for age. What is the most likely mode of inheritance of this condition? So he obviously has classic myotonic dystrophy type 1, which is autosomal dominant. That's all it was, right? The dysphagia, the testicular volume being low, and the very interesting way his muscle dystrophy is actually occurring is all unique, right? And then of course the age also helps here. As long as the patient is over age 5, you really don't want to think of Duchenne. Duchenne is severe, so it happens at a very young age, right? And this table breaks down more into what you see in myotonic dystrophy. Similarly, we have this question over here again for the same topic. So now we have a 28-year-old woman, right? So female patient, 28-year-old woman comes to the office due to stiffness and weakness of her hands over the past several months. She has had decreased grip strength and frequent episodes in which her hands felt so stiff that she could not let go of objects. Remember that the key thing, as they tell you right here, is the abnormally long handshake, right? So we saw the hand problems in the previous guy. We're seeing hand problems in this girl. She also reports fatigue and excessive sleepiness and says, I could sleep 20 hours straight and still wake up tired. She has had occasional difficulty with speech, which she describes as mouth slurring, and heavy feeling in the tongue. She has no prior medical conditions, doesn't take any medications, vital signs are fine. Physical exam, which we always care about in every single question, shows a flat affect and mild bilateral ptosis. Hand grip is weak bilaterally, and mild atrophy of the small muscles of the hands is present. Deep tendon reflexes are normal throughout, and Babinski sign is absent. No neurological problems, so her muscular issue is not due to a neurological deficit. That's why they're giving away all that information. When she is instructed to repeatedly close the eyes tightly, there is a noticeable lag when she opens them. So everything is slowing down, which is why they have an abnormally long handshake. In fact, it's not that their hand is really muscular, so they grab your hand and can't let go. It's because the muscles are dead that once they grab your hand, they can't send the signal to open. It's just there's no muscles there. It's a very weak hand. That's kind of what happens there. Now look at how confused everyone was. So they asked, what is the most likely cause of her condition? And because it's a female, we never really think of muscular dystrophies with women patients. Only 30% of people got this question correct, that it was a CTG trinucleotide repeat expansion. 50% of people chose anti-acetylcholine receptor antibodies, which of course then goes into your myasthenic diseases. And 10% of people chose abnormal production of thyroid, which is hypothyroid. But hypothyroid would have weight gain, she would be feeling cold, a couple things. Now, of course, her flat affect is also a hypothyroid kind of thing, which really make them think about that. But when you see certain answer choices in your questions, you should go back and reevaluate the question as quickly as you can to see if it fits that scenario. If it fits. So if you see this answer choice of, oh, this CTG trinucleotide repeat, if you see that as an answer choice, then it's very much necessary at that point for you to come back and check, does the question scenario fit CTG trinucleotide repeat? Let me see, what is this? This is from NVME 7 of step 2. So they gave, of course, as always, remember NVME, look at the pictures I've put here, right? This is like straight up fact right now about how trash NVME is. This is the image NVME gave. This is a normal image I found on Google. So clearly NVME is using images from like the first day x-rays were invented, because I don't see why any x-ray would look so downright hazy and ugly, right? As you can see, the clear difference, it looks like you took something from 280p to straight up 4K HD, right? So that change is really drastic. But of course, we're required to know things no matter how shitty an image is given. So this was a step 2 NVME question saying, an otherwise healthy 37-year-old man comes to the physician because of a 3-month history of low back pain. Use of NSAIDs has provided moderate relief. Forward flexion of the spine is fine and does not produce pain. Hyperextension, meaning bending backwards, increases the pain. Muscle strength in the legs is 5 out of 5. Sensation and reflexes are normal. Lateral x-ray of the lumbar spine is shown. They didn't have the arrow. I put this arrow there. Let me see. Yeah, I put the arrow there and took the picture like that. Muscle strength in the legs is like that. Lateral x-ray of the lumbar spine is given below. What is the most likely diagnosis? So you would look at this lateral x-ray, and of course you would first check each of these to be the correct size, and they're fine. There's actually pretty good space in between each of them, so the intervertebral discs are fine. But then right here you can see there isn't much space for things to move, and if there's a problem with hyperextension, bending backwards, then you must be crushing something when your spines are bending backwards, and that's kind of what's happening here. So the answer here was this topic, spondylolisthesis. They literally have a sentence to describe it, right? Developmental disorder caused by forward slipping of the vertebrae that causes bowel and bladder symptoms, lower back pain, and a palpable step off on physical exam. So forward sliding, right? What you're seeing is, you see how L5 is more forward than S1, right? It's supposed to be further back. And same thing's happening here too. Like this line was supposed to follow like that, right? This line should follow the S1. It's moved forward for whatever developmental reason. And because of that, when this person bends backwards, right? When either of these x-rays, when the person bends backwards, obviously this bone is going to crash into this bone when they're hyperextending their back. This is all you're going to get. And then you pick spondylolisthesis as your answer choice. Remember, MSK questions on step 1 and MSK questions on step 2 are both very hard. They're hard because if you haven't studied it enough and you don't know the little minute differences between all these symptoms, you won't know why something is happening. So the second thing that you might get in the question that they didn't give in this question is that this forward movement actually impedes on other structures that were in the front, right? And that's how you get the bowel and bladder symptoms. And also remember, your sacral plexus of nerves over here was also part of the micturition reflex of urinating. So all of that gets messed up, right? So the patient may come in with 2 key symptoms of lower back pain and bowel or bladder symptoms, mainly bladder symptoms. Less likely it's a bowel issue. The bowel issue is actually a physical impedance. Like the movement of this moving forward is actually pressing down onto the rectum, because the rectum is the most further backside thing. All right, so left image was in the question, and I put the orange arrow. Above is another lateral x-ray with the red arrow showing the forward slipping of L5 over S1, while the black arrow shows the spondylolysis that caused it. Right? So again, they are clearly purposefully using an extremely distorted image to, you know, make us fail, basically, because never in our real practice are we actually going to get an image this distorted. You know, it's not 1900s anymore. So it would have been much more respectable if they gave such an image like this one, but that's NVME right there. So that's your topic of spondylolisthesis. Very straightforward topic, very simple topic. The lack of other symptoms is always critical. Remember, you don't see anything else besides possible bladder symptoms and back pain. That's it, right? Nothing else is happening, so you don't pick any other answer choice. Every single other answer choice you would see may have some other thing there that you should see in the patient. You know, each of these other answer choices may have another symptom that is critical to the patient. You don't see that symptom, you don't do it. Okay, you don't pick that answer choice. Now, before we move on to some of these other things, which are also actually, yeah, we'll keep going on. We'll look at the rest of these too, because these are all, again, one sentence descriptions, right? So now what you want to do for these one sentence description things is continuously Google to find any image necessary. Otherwise, if you ever see a practice question on any of this, annotate it into the book somewhere. Or if you see a question and it presented with some key symptoms, annotate those key symptoms into the book, right? So this one is metatarsus adductus. So remember, adduction is to bring things together, right? It's addition. Adducting your eyes is bringing them both to the nose. Right? Any adduction is bringing it in medially. So this is a congenital deformity of the lower extremity where the forefoot is turned inward. If the foot is flexible, no treatment is indicated and the condition may be observed for spontaneous resolution. So this is going to just be a very easy question where you simply have to pick no treatment. But remember, picking no treatment is often a very difficult answer choice to pick, so it gets hard, right? But just no treatment. You don't need to do anything. No surgery, nothing. As long as they're mobile, they're not having any difficulties functioning in life, then they're good to go, right? Clubfoot, we've heard of it a lot. We may all have a friend who has clubfoot, and it's not the most rare thing. Congenital deformity of the lower extremity presenting with forefoot adduction and varus of the calcaneum, talus, and midfoot. In contrast to this, metatarsus adductus, the foot is not flexible and requires immediate treatment with serial casting. Surgery is performed within 3 to 6 months if it does not resolve. So of course at this point, what are you supposed to do? You're supposed to look up a quick picture showing you metatarsus adductus versus, I'm going to look up talipes equinovarus. Because if you look up just clubfoot, it'll probably show you clubfoot from like newborns with other reasons of having clubfoot. So okay, here first we're seeing this one. This is a pretty good picture. This picture is showing straight up just a normal foot being compared to a foot with metatarsus adductus. So you see all that's really happening is that it's the big toe, that aspect is all bent medially, more inwards. Okay, that's your metatarsus. And this here, this is actually an image of a real baby with clubfoot. I never understood why every time I paste a picture in here that it pastes so massively. Alright, so actually it really is a big picture. Alright. That here is showing you clubfoot. You could tell it's clubfoot only because of this fold that's happening. You see this crevice right there? That's not normal. You could actually see the same crevice in this drawing as well. Right? That's not supposed to be a thing. It's supposed to be linear, right? So now, of course, being the fact that this is a metatarsus adductus image and this is showing you clubfoot, clearly they often look very similar. Right, so this is what I mean when I say that these questions are often going to be very stupidly difficult and you're not really going to have a good time figuring it out. Now, who actually requires treatment? Neither of these two, as far as we can see right now, none of these people require treatment, but this person does, right, for very obvious reasons. This is extreme. Right, so this is also the second case scenario, talipes equinovarus, right here, right, because you can see that this person is not really going to be able to flex their foot very well, right? They can't. It's just bent in an excessive manner that will definitely make it functionally incapable in everyday life. They definitely can't run or anything with that. Now, there's a ton of pictures all over the internet to really figure these things out, but the real thing is to actually just hope that you're one, hope you don't get a question on it. Two, hope that if you do get a question on it, that it's pretty straightforward. Here you can see three different scenarios drawn by cartoon imagery, where you also have calcaneovalgus as another thing, right? Because there are other variations of these things, and of course you're gonna have, you've all seen it. You study metatarsus, you study clubfoot, you do a question, and calcaneovalgus is also an answer choice there, and then you're like, what is that? So this is why googling things is so critical, because you learn about many more variations. In fact, I like this picture the most. Let's look at this one. This is actually the most accurate drawing of a human foot. So here you can see all the different variations that are of course going to be your various other answer choices, right? Not all of them actually require any surgery, right? Not all of them require surgery. So if we're looking at just the equinovarus condition, equinovarus, remember the varus and valgus maneuvers that you could do? So equinovarus is this one right here, equinovalgus is on top of it. Right, so varus is more medially, valgus is lateral. The L in valgus is supposed to remind you of lateral. Right, so this one is bent outwards towards the pinky toe. This one is bent more medially, right? And then the others are showing you different, bullshit variations of the thing. You can get many variations of the thing. You hope that when they give you this question, they are very accurate with it. But it's very difficult to write a very good question on this. I can only imagine how much information you would have to give, and God forbid they give you a picture. That would, either if they're going to give you a picture, hopefully it's a very accurate picture clearly showing you the person needs surgery. Otherwise most of these look the same, so it's not easy. All right, and then the last thing here, developmental dysplasia of the hip, also called congenital hip dislocation. Excessive hip flexion in utero because of breech presentation, which is problematic, usually requires either turning the baby, as we learn in obstetrics, or, and again, you can only turn the baby. Remember that, I forgot what the term was for turning the baby, but you can only turn the baby if there are no contraindications. If the mom has had previous surgery or previous cesarean delivery, you can't turn the baby, because a cesarean uterus has that scar tissue. If you try doing weird things, that scar tissue can rupture, right? It's already pretty stretched out when the baby is so big. We're assuming we're at 37 weeks at this point. You can only do the turning at 37 weeks, 38 weeks. So if you can't turn the baby, then you want to try doing a cesarean delivery again, right? Which makes sense, because if you had cesarean last time, you should get cesarean again next time as well. This is why you avoid cesarean in the first place. Any patient that had vaginal delivery the first time, now you could try doing vaginal again by turning the baby first. So assuming you were able to turn the baby and deliver it, there's a chance of many things that can occur, especially if the baby's too big. Then you get the shoulder dystocia thing we looked at. Here we're looking at hip dislocation. Leads to excessive stretching of the posterior hip capsule, causing lax musculature and contractures. Can result in subluxation or dislocation of the femoral head, leading to early degenerative joint disease. Now, in step 1 MSK, there was a really good Netter's thing I had added in to explain that kind of thing. Let's take a look at, should be here somewhere. No, definitely in pathology. Okay, here we go. So the infant one is this thing right here. You see? Congenital hip dislocation. This was discussed in step 1 as well, but not so much. The whole group of childhood developmental disorders, you got developmental dysplasia of the hip, like calpertys, all these things that you need to go back and review again if you haven't looked at it in a long time, or if you completely forgot all of them. But congenital hip dislocation is the topic we're looking at right now, which from Netter's perfectly showing you how you're supposed to fix it, which is probably going to be your step 2 question, right? The step 2 loves to ask what's the next best step. So in the United States, 1.5 thousand infants are born with congenital hip dislocation. With early diagnosis and treatment, about 96% of these kids will be just fine. Girls are affected more often than boys, and about 60% of affected kids are firstborns, which may suggest that unstretched uterine and abdominal walls limit fetal movement, because the first time a woman gets pregnant, the uterus hasn't stretched out that much. So you have the Ortolani's test and the Barlow's test, right? The reduction test and the dislocation test. Both of these are being shown how you're supposed to do it. in your questions, the answer choices you might get, or the description of question wording in the question stem that you might get, may not actually obviously use the name Ortolani or Barlow's test, or they may. But if they don't, then they're going to describe how they're doing it, right? So with the baby relaxed and content on firm surface, hips and knees flexed to 90 degrees. As you can see, you got the right angles in both of them. Hips examined one at a time. Examiner grasps the baby's thighs with the middle finger over the greater trochanter and lifts the thigh to bring femoral head from its dislocated posterior position to the opposite acetabulum. Right, so you see how it's just going to grab the baby and pull towards itself, right? That's your reduction test. Simultaneously, thigh gently abducted, reducing femoral head into the acetabulum. So you basically pull the leg out and then move it into where it's supposed to sit, right? The femoral head is supposed to sit in the acetabulum. You move it back in there. Hopefully that'll make the baby feel better. The other thing is the Barlow's dislocation test. These are not just tests. These are also a diagnostic. These are both diagnostic as well as therapeutic. It treats the problem as well. So this is the reverse of Ortolani. You can see from all the arrows the way they're pointing. This is pointing down, this is pointing up. If the femoral head is in the acetabulum at the time of examination, Barlow's test is performed to discover any hip instability. Baby's thigh is grasped as shown in the adducted with gentle downward pressure, like that, pushing it down into the baby. And then dislocation is palpable as the femoral head slips out of the acetabulum, right? If you're pushing the knee into the baby, the femoral head may actually slip out, which will tell you that there's a problem, right? If it's a problem now, when the baby stands, eventually by age 1 year, it's going to still be a problem, so you need to resolve it, right? So both of them are different case scenarios, different answer choices. This one is when the femoral head is not already in the acetabulum. This one is when the femoral head is in the acetabulum, right? Depending on what's happening, you do the opposite and you move it back in or take it out and see if it actually came out. Right here, you're taking it out to see if it actually came out. You're putting pressure onto the baby to see if the femoral head slips. Right? Femoral head slipping, again, can look like this as well. Here you're seeing slipped capital femoral epiphysis, which is something that occurs in mostly obese young kids under age 5, really overweight. Right? This is showing you right here very nicely. Let me make it bigger. Very nicely showing you that this is not sitting where it's supposed to. Look at the left and right one. Right? If you look at the difference here, it's supposed to look like an ice cream cone. So they often describe it as the ice cream part falling out of the cone. Here you have your cone with the ice cream on top, right? And you can see the cone here doesn't have the ice cream on top. It fell out. Right? So it's a very clear understanding of that. So how do you fix it? You fix it like this. You put it back into position and then just screw it together. Right? And one of the most significant things for this child is going to be to lose weight, because when they stand and they have all that weight above, it pressures right onto that. Right? So if they're ever doing any kind of weird activity, of course, it's just going to cause them to have really, really bad pain and not be able to walk on that leg anymore. Here we're seeing some more step 2 relevant tests that can occur. I put step 2 things into step 1 book as well, because most step 1 questions mention these step 2 things in the question, just to see if you even understand it, and then it helps you actually pick the answer. But if you've never done studying on it, you won't actually know it occurred. Right? So here what you're seeing is the actual testing you can do for someone who has this issue. Right? So let me see. So I wrote here, affected leg externally rotates on hip flexion. Right? So when they do hip flexion, the leg would externally rotate. This one here is showing you normal left hip. When they flex the hip, you see it stays straight. Here is showing you right SCFE, slipped capital femoral epiphysis. The right leg is rotated out. Right? When they just flex the knee, flex the hip, you see how it's rotating this way in a weird way, right? So that's kind of what's happening here because of this weird loss. And this matches, the x-rays actually match, even though these x-rays are not for this person. This looks like, I can't really tell. This may actually just be a big kid, or it might be an adult. It looks like an adult to me. Yeah, definitely an adult actually. Really big leg compared to the patient, the physician that's holding them. So this is an adult, possibly overweight adult. What you're seeing is when they flex the right hip, because this has occurred in the right femoral head, the leg goes this way. Right? That's external rotation. That's bad. right? This is a giveaway for its slip. So when they tell you this in a question that, oh, flexion, hip flexion causes external rotation of the right leg, giveaway for slip capitofemoral epiphysis, and you move on. But that's what makes these musculoskeletal questions so hard, because you would have one thing that was given and that gave you the answer. So if you didn't understand what that one thing meant, then you get lost and you try to pick another answer choice that maybe fits that one scenario they gave, and hopefully you pick the right thing. So that's what this was. They go on to talk a lot more about this actually, right? This is, yeah, developmental dysplasia. They say most commonly found in firstborn girls in the breech position, just like we read about it over there in the Netter's image. High risk with family history. They actually mentioned the Barlow and Ortolani maneuvers here, and they also mentioned the Galeazzi sign. So in CK, it's actually mentioned, right? In step 1, it's, I think they only say it. I think yeah, they do mention the name. You see Ortolani and Barlow, but they don't really do too much. You know, so it was mentioned in step 1. It's more significant in CK, right? This thing, congenital hip dislocation. And what is this? The Galeazzi sign. So the knees are at unequal heights. Well, yeah, of course, right? When the hips and knees are flexed. So the knees are not going to be at equal heights for obvious reasons. And the dislocated side is going to be the side that's lower because it's dislocated. Asymmetric inguinal skin folds that extend beyond the anus and limited abduction of the affected hip are also seen. Diagnosis. Early detection with physical exam is critical to allow for proper hip development. Perform an ultrasonography before 6 months of age, given the lack of ossification. Remember, you never really do x-rays for infants because their cartilage is still young. If you do an x-ray on it, it's not really going to develop anymore. Right? X-rays are appropriate at more than 4 to 6 months of age. But even there, you want to be careful. If the ultrasound will resolve it, then just do the ultrasound. You don't need to do an x-ray. Treatment. Begin treatment early. May self-resolve before 2 weeks of age. Under 6 months of age, you could use a splint with a Pavlik harness to maintain the hip flexed and abducted. This is also going to help prevent avascular necrosis. Right? Don't flex the hips more than 60 degrees. Remember that the femoral artery is just sticking out right there from the femoral head in the acetabulum area. It can easily break. There were actually many things you have to know about that. Let me see if there's a picture for that. The femoral artery. There was the lateral and the medial femoral artery, and one was more critical than the other. I believe it was the medial one. So those are some things that you can have more commonly on step 1, not so much on step 2. Let's see if anything pops up. Can't remember exactly which one it was. I'm leaning towards thinking it was the lateral femoral artery that was actually the more significant thing for avascular necrosis. But actually, we can find out. Let's just confirm it. Avascular necrosis. Let's see where we find that. Oh, right. It was right there. So leg calpertys disease, idiopathic avascular necrosis, the femoral head, commonly presents with age 5 to 7 years. They don't mention it here either, though, which artery is going to be. Oh, there you go. Perfect. So this is what we're looking for. This thing. Avascular necrosis of that bone. So you see how you have the obturator artery coming from inside, right? And then outside you have the medial femoral artery and the lateral femoral artery going around. Right, so this area where the two guys meet, remember this was true in GIT also, where two different arteries meet. When I was new to medicine, I used to think, oh, so you have dual supply, you should be great. Actually, it turns out it's the opposite. So when I was no longer new in medicine, I learned that when you have dual supply, it actually means that both of them are being stingy. Right, so they both minimally send blood. It actually turns out that this area needs blood from both of them. So if either one of them stops sending blood, it loses a lot of blood, and then without that blood supply, there's going to be problems, right? Now, who's the more important artery isn't really mentioned here either, but I think I vaguely recall doing questions where the problem was with the lateral femoral artery being the more significant one, but I can't remember that question. So if you do see it, definitely shoot me a message, let me know. I don't have it as a note here either. Oh, never mind. Okay, it's actually right there. Most common site is femoral head due to insufficiency of the medial one. Okay, so that's the more important one, medial. Right. That if you get a question on this, they'll have both answer choices there just because one is more important than the other. Right. So it's good that we found this here. Good revision. Medial circumflex femoral artery is more likely to, for some reason, be insufficient and not bring enough supply. So you have to make sure you don't mess that artery up while you're doing displacement stuff. Now with the newborn, those ortolani and the other maneuvers that we're doing, pulling and moving things around can definitely rupture these arteries, but it's inevitable. You have to do it so you can place it into the acetabulum correctly. And since it's newborns, infants, they have like this crazy godlike stem cell regenerative powers, so they'll be okay. They'll recover. The number one thing is to stop the pain, because that displacement that occurs really messes up the baby's mood and actual stability, hemodynamic stability. 6 to 15 months olds can get a spica cast, whereas 15 to 24 months old, which is now being 2 years old, can actually get open reduction followed by the spica cast. So now that raises the question, what is a spica cast? So if we look at it, it's basically just a cast, nothing special. This is actually pretty cute. There's a picture of a spica cast right here. So it's something like this. This is the most important part of the spica cast itself is this rod in the middle. It's to stop them from crossing their legs over. Remember that because the femoral bone is not sitting correctly in the acetabulum, right? It's actually the other way around. It can actually bend this way, right? And that's what we saw with slipped capital femoral epiphysis with the adult, right? We just saw that the external rotation thing that was occurring, and that's occurring because of that issue, that the bone that's not sitting in the acetabulum likes to bend that way, right? So it's not gonna bend the other way. It's not gonna be doing that. That doesn't, I don't know, for whatever reason, doesn't occur, but it does bend this way. This can occur, right? So you stop that using this prevention method. All right. You gotta go? Okay. So that's your spica cast. Very interesting maneuver. Does the job, stops everything. If you don't use it, then of course the baby can worsen their own displacement. And if the parents are not careful enough to bring the baby in early enough, then of course things are just going to continue to get really, really bad, which sucks. And there are parents like that. There are many parents where the number one case scenario where this is an ethics question, where a patient doesn't want to bring their child into the hospital even though their newborn is having problems, is in a family with an abusive one of the parents being an abusive parent. So for example, imagine a scenario where a woman has a very abusive, physically abusive, emotionally abusive husband. They live together and they just had a child. Every time that man brings this wife into the hospital, he risks getting arrested because she may give off some kind of mood or aura or some kind of pain or some kind of scar, bruise, whatever, to the hospital physician, and that's obviously going to spark questioning about physical abuse. Now you can't do anything if a woman is being physically abused by her husband inside the house. Can't call the cops on that. But if this issue is leading to the child not getting good service because the mom can't come to the hospital whenever the child needs to, simply because the husband is afraid that he's going to get arrested, that you can call child protective services on, right? Because you're delaying child health and ignoring child health simply because the husband and wife are having constant fights and the husband is scared to come out because he might get arrested, right? So you're going to have both answer choices: report the husband to the cops. You never do that, right? Advise the woman to get a divorce. You never do that either. Not your job to advise divorce. But report the child's health being delayed to child protective services, definitely, right? CPS is going to take that child away from the family and put them with, put the child in a better environment. That's a ethics question where you see the 30-30-30, people are all over the place. 30% picked A, 30% picked B, like that kind of thing happens in that. Right, so avascular necrosis is what you're avoiding here, which we know now the medial femoral artery is the more significant aspect. Right, And that, of course, leads to the topic of like calpertys disease, which is just idiopathic avascular necrosis. Um, it's usually not an idiopathic thing, though, right? As we just saw, usually avascular necrosis occurs for a very valid reason, which is one of these things, right? And that's the mnemonic of casts bend legs. So corticosteroids, alcoholism, sickle cell, very common because you can imagine the sickled cells, sickled red blood cells are going to get stuck in these tiny arteries. Trauma, lupus, of course, like calpertys, the idiopathic one we're looking at right now. Even Gaucher disease. Remember, Gaucher was the character inside the trash can from the TV show, so we have a very good character for that. Slip capital femoral epiphyses, which we just looked at, right? Being born with the epiphysis not being inside the acetabulum. Multiple reasons it can occur. So now we're looking at leg calpertys disease, idiopathic avascular necrosis of the femoral head, most common in boys 4 to 10 years of age. Can be self-limited disease in younger patients with symptoms lasting under 18 months, but that's a long time to have these symptoms. Generally asymptomatic at first, but patients can develop a painless limp, antalgic gait, and thigh muscle atrophy. If pain is present, it can be in the groin or anterior thigh, or it may be referred to the knee. Limited abduction and internal rotation, atrophy of the affected leg, usually unilateral. Diagnosis: initial x-rays can be normal, but later it can show a flattened and fragmented femoral head. Observation is sufficient if it's limited, right? Limited femoral head involvement, or if full ROM is present. But if there's extensive issues, or if there's decreased ROM, consider bracing, hip abduction with a Petri cast, or an osteotomy. So here we have another cast, the Petri cast. This is why there's a lot of Googling you have to do when you're studying here. The Petri cast is pretty much the same exact thing, but for more grown-ups. So this is a wonderful picture. All right, here we go. Always better to see a picture with a happy person. So you can see not the clearest picture, but you can see the cast. So what it's doing is keeping the legs straight, and it's keeping the patient from crossing the legs in, right? So of course they're not going to be able to do much mobile things at this point. They cannot walk at all, right? But it's necessary until it stabilizes and things get better, right? This is exactly what needs to be done. Can't do anything else about it, because if you let the patient, bend their legs, they're gonna further worsen this significantly, right? So that's your Petri cast. Petri cast, the other cast we just looked at right here, spica cast, they're the same thing. The spica cast is for infants. The Petri cast is for the more grown children, right? I'm guessing they probably have an adult version of it as well. So these are some critical things that you need to be aware of, and you only pick those answers if the patient is at a point where things are not looking so good, right? If the patient is doing okay and it's just a little bit of a problem, then it's not the worst case scenario. So these x-rays all look really bad, right? This is showing you avascular necrosis of the femoral head in both of them, actually. So what you're really focusing on is the difference between the two. Every time you get this kind of an x-ray, you focus on the difference between this and this. And you can see between these two, the one that looks really problematic is this one. So they zoomed in. And you can see how it's all cracked up now. You don't see a very smooth ice cream. Can't see it. It looks like this is it. It's all cracked up, right? And it's sitting inside the cone, but this is going to be really, really bad, right? Because this isn't slipped capital. This is just a necrosis. It's just broken. Right? At any time, it can slip too now, because now you don't have that nice ice cream, so it can just slip out. Okay, really problematic. So when you see this in questions, the focus is always on this aspect right here. Very straightforward topic, but it can look a little confusing sometimes, right? This then leads on to the same thing again, slip capital femoral epiphyses, which we just talked about. Right? X-rays of both hips in the anterior, posterior, and frog-leg lateral views reveal posterior and inferior displacement of the femoral head. Right? So you can see here, they've got the red arrow and the blue arrow, right? You're looking at both of them at the same time. And what looks problematic here? So they're telling you frog leg anteroposterior x-ray demonstrates medial and inferior displacement of the right femoral epiphysis, which is the red arrow, relative to the femoral neck. In comparison, the left is normal. Right, so how do you notice that? What is it actually showing that's telling you there's a slip that's happening? Well, the slippage remember that this needs to be sitting inside this, right? Here it also looks like it's sitting pretty well, but there's a big amount of it that isn't, right? A little too much of it that isn't. And honestly, I wouldn't say this is the best image to use for actually teaching this, but to test somebody on it, you always want to use asshole images, and this is exactly that. In this case scenario, both of them look very normal. They look very normal. There's no major difference between the two that really makes it look like there's a problem here. Better images, you know, for a good test writer would be something like this, right, where you can clearly see the slip that occurred, right? The ice cream has fallen off the cone, right? You can't really see that. So if they do a frog leg thing, it becomes difficult. Frog leg is literally like laying like a frog that's on their back. So your legs are just open and straightened as much as they can laterally. They're saying that this is what? Medially and inferiorly displaced. So medially and inferiorly, yeah. Again, I don't think that is super clear. If anything, this looks very normal, right? So not the best image for teaching this. However, on your test, hopefully you're going to have something that's much more clear, much more evident, right? In this image up here that I just showed, it's very evident. And this image from the step 1, very evident, right? The ice cream has fallen off the cone. That's all. That's how all the radiologists describe this thing, right? This image is really bad for that. Treatment, disease is progressive, so treatment should begin promptly. Immediate surgical screw fixation, like that. And no weight bearing should be be allowed until the defect is surgically stabilized, right? Of course, you don't want to jump or anything like that. Chondrolysis, avascular necrosis of femoral head, and premature hip osteoarthritis are all things that can occur inevitably, right? So these are like, there's nothing you can do about it, depending on how much the patient weighs, what kind of activity they do, all kinds of problems that can occur because of not really taking care of yourself, right? Last thing here is scoliosis, which we all know is just a weird bending of the spine, right? Lateral curvature of the spine more than 10 degrees, sometimes associated with kyphosis or lordosis, like in Duchenne. Most commonly idiopathic, developing in early adolescence. Other etiologies are congenital or associated with neuromuscular, vertebral, or spinal cord disease. The male to female ratio is 1 to 7, so mainly occurs in females. For curves that progress and require treatment. Idiopathic disease is usually identified during school physical screening. Vertebral and rib rotation deformities are accentuated by the Adams forward bending test. So let's take a look at what that is. Oh, okay, yeah. So when you do this, you could tell who has scoliosis and who doesn't, right? You can see the normal person bending forward, it looks nice and even. The scoliosis patient bending forward, you can see the spine is bent and this one is sticking out, right? Because of the bend, it's not bending down. Because the bend on the scoliotic spine, this is sticking out like that, right? And all the pictures are showing the same kind of thing. There's actually a bunch of real pictures too, with real patients having that bend. And then this is actually a pretty good picture here too from a drawing. Right, so you're seeing what's happening and what's causing this to stick out when they bend over. Right. So definitely problematic. Very rarely surgically fixable. You can't really, because there's too many nerves in here for you to try bending any of these things. Would probably be more fixable at a newborn stage, but there's no scoliosis when they're just born. At that point, it's actually pretty straight. Close observation, spinal bracing, and surgical correction for extreme curvature, but you can't do surgical correction that easily. It's not that easy. It's much more easily said than done. Right? Usually, you'll see the spinal bracing as the answer choice. That is the correct answer. Right? So if they tell you more than 50 degrees of curvature, then pick surgical correction, but usually they'll pick something like 30-degree curvature or something, and you do spinal bracing. You actually add braces so that it stops curving more, unable to curve more. Okay, that's the concept there. And that's it. That's all your little MSK things. I think all the slip capital, leg calpertys, all those are not so bad. Everything about the hip was not so bad. These two topics are a little confusing. And spondylolisthesis was its own little thing. Can't bend backwards correctly. And then we had our Duchenne, Becker, and CTG repeat muscular dystrophies. That's it, right? In the next video, we'll go through some of these orthopedic injuries, which we'll also have to go back to step 1 for to look at them. We already looked at even sarcoma and that one. So we'll look at these orthopedic injuries, and then we'll wrap up with child abuse and be done with pediatrics later tonight. All right. Thanks a lot for joining. I'll see you guys again.